I've originally been given half an hour to cover this subject, but actually having listened to the presentations this morning, I suspect what I'll be doing is repeating and reinforcing a lot of what you've already heard. Not that that's a bad thing, of course, but I'd hope to be able to condense it down to about 20 minutes. Although on this issue of using standards, what I would like is, I suppose, to generate some discussion about implementation of standards, because that's the real challenge. I think what I'd like to do by way of introduction, actually, I'm going to ask you to indulge me. I want to give you some very personal thoughts that emerged when I was returning from holiday last week. So just take a few minutes to talk you through this. I was at Munich Airport. It was a Sunday afternoon. And what I really wanted, actually, was to catch up with the latest commentary on the Test match. But the emblazoned across the front page of the Sunday Times was yet another story about the killing fields of NHS hospitals. And I suppose my first response was one of embarrassment, particularly as this was a health service that we'd lauded so internationally just about a year ago. And here it was being denigrated in a really public forum. So I had a sense of embarrassment. But I'm not quite sure how you all feel about the barrage of constant bad press that the NHS gets. Because I've actually come to view it as positive, which may be a strange thing to say, but it means transparency. It means actually our becoming aware and creating the public debate that we need to have in order to instigate change. And I think it's going to become the most powerful incentive and driver to change that we have, because we have a burning platform. Anyway, I picked up the Sunday Times, and in the departure lounge, I read Camilla Cavendish's article, and it was about, it's her drive to 7/7, join the campaign for 7/7 services, which actually I'd very happily sign up to. No problem at all. And in the article, she made reference to why can't the health service have the same safety profile as the airline industry? And I thought that was quite opportune, really, because as I sat down waiting to take off, I don't know what you're like when actually you have to go to the safety briefings, but I usually have my iPod in to the last minute until someone tells me to come and take it out. I'm never quite sure why it interferes with aircraft electronics, actually, or reading the paper. But on this occasion, I thought I would pay attention. So the captain came on. Good afternoon, ladies and gentlemen. This is your captain speaking. We're going to be cruising at 35,000 feet. I'm sorry if there's any delay in takeoff, if it's inconvenience to you. The weather on the way is going to be fine. There'll be no turbulence. We'll be landing in Gatwick at 2032. In the cabin with me this evening, I've got my co-pilot, and your cabin crew, Pew, Barney McGrew, Cuthbert, Dublin Grubb, are all there for your safety, for your personal satisfaction, and to help you. And we will be serving drinks along the way. So what did I get from that? I actually had a sense, first of all, that there was clear leadership. Secondly, I had a sense that there was good team working. Thirdly, I had a sense that there was a corporate belief and understanding of operating to standards. And fourthly, I had a belief that I was being given the right kind of information that I wanted in order to make my journey a satisfactory one, and sure enough, landed in Gatwick with my bags on time, as I might have expected to. Now, this is where you're going to have to indulge me, because I had a flight of fantasy here. What would it be like if this was flight NHS 2013 to any city? Captain comes on. Good afternoon, ladies and gentlemen. I'm your captain. I'm actually not used to doing this safety briefing. And in fact, I'm not going to be with you the whole flight, because I'm getting off at the first leg. Actually, because it's a Sunday afternoon and because we've got some pieces of navigational equipment missing, it may be better just to carry on cruising till Monday morning, when we'll find a landing slot, hopefully. I have got my co-pilot on board. He's a very young and enthusiastic chap, and he has actually landed this aircraft once or twice before, so I've got a lot of confidence in him. And if he's got a problem, I'm always there. They can patch me in. I'm on the end of a phone. Now, it might be a little bit turbulent along the way. We are actually missing a couple of members of the cabin crew. But I'm hoping before we close the doors for takeoff that they'll join us. I hope they can communicate. I hope they've got an understanding. But if they haven't, we've got all the guidelines, the protocols that they can follow. So don't worry too much about that. Now, I know as well that there seem to be lots of you. There should be other cabin assistants as well, but I'm not quite sure how many of those we've got. So if you want refreshments, just hang on, and you might get them at some stage. So I'm painting a slightly different picture. That was my flight of fantasy. Lack of leadership, lack of team working, lack of a corporate understanding of the requirement to work to standards, and lack of or poor quality patient information. And actually what patients expect, of course, is that we do run services to a set standard, and we don't. And that's why I come back to my point about the national papers that we see on a regular basis. That is the most powerful driver for change, and we have to change. So that's by way of introductory preamble. I hope that wasn't too long. Now, which button was I going to press here now? It's this one, isn't it? Here we go. Now, so I'm going to talk about standards. Many of you will have heard this before. It's the Quality and Safety Programme. I want to talk about the history of the programme, the development of the standard, key themes, audit outcomes, and some reflections from the Clinical Senate. Many of you may or may not know what the Clinical Senate is, but I think it's going to be quite an important and influential body across London because it brings a group of clinicians together who hopefully will have an influence on the system. So I'm going to share with you some of their thoughts. Just on the history of the programme, first of all, I initiated this 2 years ago now, I think, for several reasons. One, there was there had been a battery of documentation from respected august bodies, NCPOD, the colleges, which had been completely ignored. And what other industry would actually ignore recommendations as they had been for such a long period of time? It's a travesty. No other industry would allow that. Personal recommendations to myself, personal concerns expressed to myself by serious individuals saying quality of care out of hours was poor. Trainees are actually working under unsafe circumstances. So something had to be done. Plus also at that stage, the recognition that there was a huge variation in mortality rates between weekends and weekdays. And there's still actually confusion about this because the national HES data was quite clear. Admission to hospital at weekends are actually lower than during the week. You don't actually die at a weekend. What happens is if you're admitted at a weekend, and that's where the risk lies, deaths occur on the Monday, Tuesday, Wednesday, and then they tail off. And the risks remain. Now, in London, actually, we have actually smoothed that profile out. But nationally, if you look at it, you've still got a 16% chance of dying if you're admitted on a Saturday, a 9% chance of dying if you're admitted on a Sunday. And that variability, again, is a travesty that we shouldn't allow. So I do want to talk at this point about something about HSMRs, because they've got a notoriety now, haven't they? We seem to be developing a fixed belief that there is an association here with avoidable deaths, and of course there isn't. There isn't. The only way you can determine whether a death is avoidable is by going through case records. But they are a useful indicator, and I show this actually because I look at this and I still feel rather optimistic about what's going on in London. London has always had a consistently lower SHA. It seems rather passé to talk about SHAs nowadays, isn't it? But London has always had a consistently lower HSMR than other SHAs had. And of course, HSMRs have been reducing over the last 10 years quite significantly. What encourages me about London is that the rate of HSMR is dropping more rapidly than other parts of the country. So whatever it is, and it's multifactorial, we are doing something that is right. And that actually needs further analysis, but this is not artifact, this is genuine. So back to how, what is it that we wanted to come out of the quality program? Well, it's actually supporting clinical sustainability. It's actually reducing that variation that still exists. We want consistency of care. We want to make sure that when your mother or my mother is admitted to hospital on a Sunday, she gets the same standard of care as she would on a Wednesday. That we don't have. So we need to eradicate the weekend effect, this war zone that occurs on a Monday morning with a logjam of patients who haven't actually been dealt with appropriately or had decisions made about them over the weekend. And of course, we're aiming to reduce excess mortality, but there is a key thing too about improving flow and improving productivity for all the reasons we've talked about this morning. So just in terms of the way we've approached these programs, our focus, first of all, has been on adult medicine, adult acute medicine, and acute surgery. But we have also looked at standards for maternity, for children, for intensive care, and inter-hospital transfers, which actually, as Anne has referred to, are an area of considerable risk. The process has been fairly standard. We review the evidence base for change, and the evidence base for change has been there, as it is in primary care. The evidence base for change is there and has been there for a long time. Developing the standards, the key thing is how can we introduce them into commissioning? What we've done with the adult emergency medicine and surgical standards is actually audit them, and it's the results of that audit. Some of you will be familiar with it, but I want to show you the results of that audit. And then we need to go and re-audit in order to actually close the cycle and ensure change occurs. They have been co-produced, and I'd emphasize that. There has been a significant number in developing these standards, 90-plus clinicians contributing to expert panels, numerous stakeholder events, and the information is there for you to see. And we have I suppose the question is, process of endorsement, but they have actually been considered in considerable detail by our clinical senate and endorsed, and also accepted by the London-wide Clinical Commissioning Council, which Howard chairs. And I must actually thank Howard for his contribution and the sort of support that he's offered throughout this. So what are the key themes? And I think this is where I'm actually probably repeating much of what you've heard this morning. This issue of increased consultant presence across 7 days of the week is crucial. And it's not a matter, and I think it was referred to in one of the talks this morning, it's not a single consultant of the day model, it's a consultant of several days in order to provide the continuity. And there's no doubt at all that if you have senior decision makers at the front line, patient outcomes are better, flow is better. And that's got to be 7 days of the week. But the key thing is consultants must be freed from all other duties when they have this responsibility. There is something about being seen and assessed by the relevant consultant at an appropriate time. Those who are high risk should be seen within 1 hour. And this isn't rocket science. This is actually fairly simple, straightforward stuff that we should be adhering to. And what I'm very pleased to note as well, actually, is this morning the College of Physicians, College of Emergency Physicians, the National Confed, NHS Confed, have produced their own 10 points for action, which actually almost directly mirror these key themes. Multidisciplinary assessment, that is probably the most difficult thing to do, which I'll show you. But this 24-hour timely access to key diagnostic imaging and reporting, these are your navigational systems that actually have to be in place throughout the 24 hours, because that's where your patient logjam builds up if you don't have access to diagnostics. Patient communication, and there is this thing as well about ensuring high-risk operations have the key people in place. And I mentioned two of the standards there. I suppose one, because the latter is, the maternity is quite controversial and difficult, and we've actually gone further than the currently accepted operational requirements for fractured neck of femur. We've adopted the Scottish position. These are the results of the audit. In terms of the standards, 50%, only 50% of the hospitals currently actually meet those standards. But the key thing is that all the standards can be met because they have all been met, but no single organisation meets all the standards. Looked at slightly differently, if we group these standards according to groups, consultant-delivered care, access along the bottom line here, access and provision of emergency theatres, multidisciplinary assessment, diagnostic access, patient experience, you'll see that the areas that we have got most difficulty, where the standards aren't met, is in the consultant-delivered care, and clearly where we are failing is multidisciplinary assessment. And that's rather surprising, but that's actually clearly, if we're going to ensure that there is continuity of flow from the community to the hospital, or not even into the hospital in the first instance, multidisciplinary working, team working is absolutely crucial. So the conclusions, then, of this audit. I think, to be honest, we know for the consultant body, I'd hope we're pushing it at an open door, although implementation of changed consultant working patterns in particular is going to be a problem. I don't think we'll ever see a revision of the consultant's contract. I'm sure Jonathan, sitting here, would perhaps be better placed than I to comment on this. But I think we do have to work within the flexibilities of the current contract to ensure that consultants' working patterns change. In actually completing these audits, the most significant challenge, as I said, is to make sure that variation and consistency of practice is there. It's quite clear. Most of the organisations we went to welcomed the approach that we adopted. I think they can see its importance, but clearly some places have got further to go than others. They are ambitious, And that's the question, of course, from our point of view, is how are we going to work with CCG colleagues in order to implement? Just some thoughts to conclude, really. We've got a few minutes. Is some thoughts of what the Clinical Senate thought in the debate we had a couple of weeks ago. And the clear view is that the key thing that is going to improve the consistency, the standards of care, is implementation of these standards, validating the move, facilitating the move to 7-day services, reducing that Monday effect, and ensuring prompt and consistent access to the right skills, right place, right time, etc. And improving the patient experience. Strengthening leadership across the system, making sure that there's a whole system approach. But I think also, we talk about clinical leadership, we do need to see that clinical leadership on the shop floor, the captain of the crew at the time. That is crucial because that's how the engine is made to tick, as well as having a whole system approach. And I think referring back to some of the discussions we were having before, taking a broader geographical approach to urgent care board formation is actually going to perhaps be a more appropriate way of dealing with this. And I thought the discussion this morning about capacity planning, capacity meaning your resource, your skills, your consultant time, and your nursing, was a really very, very powerful and cogent point. So we need to think differently about demand and capacity planning, and the use of appropriate data that everybody understands across the system is crucial. It needs to be shared widely and also cascaded down to those who are working at the front line, so that they have a clear picture of what their role is within the organisation, and it has to be a complete corporate approach within you, and that's not what happens at the moment. Often A&E services, for example, are left on their own to cope without any real input, and you can see communication channels breaking down repeatedly. So this whole system approach, whole system leadership is going to be crucial. I want to leave you a couple of things, what can be done. And I want to show 2 slides, really. We will be landing in 2 minutes. This is Coordinate My Care. This shows care planning for patients at the end of life. And it shows deaths occurring at home, in hospices, care homes, and in hospital. There's the London figures, the England figures, and those patients who've been on the Coordinate My Care pathway. What we're seeing here is a very significant increase in those numbers dying at home, patients dying at home, and a very significant reduction in patients dying in hospital. And that's actually quite powerful data. And if, thinking about multidisciplinary assessment of these patients with complex needs in the community to ensure that they have a death that is of high quality is not only going to be effective for them, it's going to be cost-saving because of the admissions that are avoided. And I show you this slide as well, which Celia gave me yesterday, and which I'm very grateful. It's early results from a pilot site of a national emergency laparotomy audit. And the key things here, adopting a care bundle approach, adopt some systematic approaches to management, but if you have a consultant surgeon in theatre and a consultant anaesthetist undertaking the work, the evidence shows there's a 29% reduction in mortality. And that's significant too. So there are key things that we can do, and we can build upon the momentum that we've gained already. What are the next steps that we're proposing? There's clearly workforce and financial modelling to undertake. We need to work with CCGs to understand how if we are going to go through a process of implementation, how we do it. We would like to see all these quality standards commissioned. We have a suite of about 130 of them, perhaps across a whole range of specialties. Perhaps that's too many, but we will be wanting to do a full audit of acute providers sometime next year because we have to pursue this line. So I suppose in conclusion, we're facing tough times here. There's a battery of problems all the time, but I think it's the best burning platform that we've got. It's the best opportunity we've got to actually make change. And I think given what we've achieved in London, I do feel optimistic that we can get through it. Thank you very much.